Good morning or afternoon, everyone. I'm Jeff Mays with Radcliffe Mays in Los Angeles and representing today the MedTech Coalition for Metabolic Health. Along with my co-chair, Leslie Zoloff, I would like to thank all of you for joining today's webinar, which is being hosted by the Business Engagement in Obesity Solutions Innovation Collaborative. The Innovation Collaborative is an ad hoc activity, as many of you know, associated with the Roundtable on Obesity Solutions at the National Academies of Sciences, Engineering, and Medicine. The IC promotes business engagement strategies for obesity prevention and treatment with a focus on the health and economic well-being of companies, workers, and their communities. The collaborative's purpose is to catalyze and facilitate private sector partnerships and actions to enhance the lives of workers by improving the nation's health through prevention and access to obesity care. You can find more information about the IC and the Roundtable on Obesity Solutions online. As a quick disclaimer, any activities and products associated with the IC do not necessarily represent the views of any one organization or the national academies, and have not been subjected to the review procedures of, nor are they reports, products, or activities of the national academies. I would like to take a moment to thank the IC membership for taking an interest in this topic today, and I would also like to extend special thanks to Gil Stevens of Novo Nordisk and Jody Mitchell at the MedTech Coalition for Metabolic Health, both IC members who are instrumental in the development of this program. Today's webinar will be recorded and the slides will be posted to the website in the coming weeks, but there will be no published proceedings. Today's topic is especially important and timely. There are so many brilliant minds working on the best practices for addressing obesity in our society and in the workplace. Yet our collective challenge is to implement those best practices where and how we can in each of our organizations. The discussion today, highlighting just one company's approach, is therefore helpful as a practical example of success and maybe to get our juices flowing. So with that, we will hear from two presenters, followed by a discussion at the end of the session. Please feel free to type your questions into the chat box during and after the presentations, and please specify if your question is directed towards one speaker or both speakers. Please note that biographies of all speakers can be found on the BEOSIC website. Our first presenter is Anthony Fabricator. Dr. Fabricator serves as Medical Director, Obesity and Medical Affairs at Novo Nordisk. Dr. Fabricator, please start us off.
Thank you, Jeff. I hope that you can hear and see me at this point. Had a little tech issues earlier. Well, thank you for the introduction, for the invitation to present. It's really a pleasure to be speaking to this group. What I intend to do, as I pull up my content, if you'll just bear with me a moment, is to give a little overview of obesity. I think that's something that will be very familiar to many people on this call. But for those of you who maybe know about obesity in passing, or maybe know a little bit, what I'd like to do is kind of set the, put everybody on an even footing. How are we?
Good.
Yes? Okay, great. Thanks, Cypress, for the heads up. So we'll start with the definition of obesity. I'm going to use the World Health Organization definition, which is an abnormal or excessive accumulation of fat that may impair health. Notice body mass index is not in that definition. We do use the body mass index, though, to estimate obesity. So body mass index, or BMI, is simply a measure of weight in kilograms relative to height in meters squared. And it is not a perfect measure of obesity, but it's a fairly good proxy for most people, and certainly on the population level. We're in the middle of the Olympics right now. We can see plenty of examples of people who are very muscular, who have maybe a high body mass, a low percentage of body fat, and their body mass index may put them in the category of overweight or obesity. But we know that is not the case because they don't have an excessive accumulation of body fat that impairs health. So if we really wanted to get very technical about assessing obesity, it would require use of imaging to, or bioelectric impedance to estimate percent body fat, and a full clinical assessment to understand the effect of that body fat on several weight-related comorbidities. But for now, and what's most typically used, and again, it's good for most of the population, we use body mass index and waist circumference as proxies for defining obesity. No presentation or no overview presentation on obesity is complete without the CDC slides on the prevalence of obesity and how that's changed in the US over the past several years. So I'm just going to very quickly hop through the years 2011 through 2018, and you can see that as the years go on, the colors get darker, a couple colors are added. And we can see now that there's what's sometimes referred to as the diabetes belt or the obesity belt in the southeastern part of the United States. One thing I want to point out, actually two things I want to point out about this map, and when you see this map or maps like it. The first is that what you see here is very likely an underestimation of the problem. And that comes from, if we look at the key down next to Florida, and you'll see these numbers, less than 20% up to more than 35%. These numbers are only good for conceptual purposes. The data set that these numbers are based on used self-reported heights and weights. Now, if you ask me my self-reported height and weight, I'll tell you that I'm 5'11" and 160 pounds. However, if you measure my height and weight, you'll see that I'm 5'8" and 160 pounds. So it's very common for people to either overestimate their height, underestimate their weight, or both. So any numbers you get from self-reported weights and heights are going to be an underestimation. So that's point number one. Point number two is that this masks the disparities in the way obesity affects people of different demographic groups. So over on the right, you'll see, pardon small text. On the top right is the prevalence using the same definition and numbers among white Americans in the year 2016 to 2018. In the middle, you'll see the prevalence in Hispanic Americans. And then the bottom is the prevalence among Black Americans, Black non-Hispanic Americans. So you can see that there is a disproportionate burden in the African American community, certainly related as compared with the Caucasian community. But as I mentioned, the self-reported numbers are an underestimate. And when we look at measured data from large population samples, we'll see that roughly 42% of the US adults right now have obesity. This slide is actually a couple of years out of date. So if we were to add the most recent bar from 2017, 2018, that's where we would see the prevalence at 42%. And if we were to add a couple of bars on the left side of this graph and trace this data set, the enhanced data set back to its beginning, we would see the prevalence of obesity at around 15% of the adult US population back in 1976 to 1980. So between 1976 and 2000, the prevalence of obesity doubled from about 15% to about 30%. And in the 20 years since, it's increased roughly by another 1/2 to roughly 45%. So what is going on? Why are we experiencing so much obesity in this country? And individually, we could stop with the simplest view. That, of course, just as a spoiler, I think that's a mistake. But many of us understand obesity to be a function of calories in versus calories out. And truly, at the end of the day, yes, body fat is stored when more calories are consumed or ingested than can be burned as fuel in the body. That does put extra calories into storage as fat. However, this, like many other simplistic explanations, overlooks a lot of context and a lot of additional factors that may be weighing on either side, or both sides actually, of this balance. So I want to demonstrate, and I think and I hope that this concept will be familiar to most people on this call, but just humor me as I go through this. The correlations between obesity and things like eating more and moving less. So again, we're looking at the NHANES data from 76 to 1980 period is NHANES 1, and this particular analysis stops in the 2000 period. But again, so you see the prevalence of obesity increased from 15% to about 30%. During that period of time, the average number of calories that Americans consumed increased, as did the energy density or the calorie density of the foods that they consumed. Also, during that same period of time, low activity jobs became more common in the workforce, and high activity jobs became less common, and we spent more time watching TV. So all of these factors, sure, they all correlate, they all are associated with an increase in the prevalence of obesity. But based on that, can we really say that the prevalence of obesity increased because Americans were eating more and moving less? To illustrate why that may not be a reasonable conclusion, I want to show you one of my favorite studies in all of the obesity literature. This was published 15 years ago. And what it does is it takes prevalence of obesity in adults over time and plots it, as you see here in orange. And I'm just going to quickly run through. Don't expect you to follow all of this and to understand what each of these relationships represents. But all of these factors here are those with a plausible biological relationship to body weight. And all of these factors also increased over time at the same time that the prevalence of obesity increased. So did diet and exercise changes cause obesity? No more than change in antidepressant prescriptions or the percentage of endocrine disruptors in the environment. These are all factors that are associated with obesity, but we cannot conclude that they cause it. The Obesity Society goes even further and looks at all of the factors, both internal to the person and external to the person, that may be associated with excess weight storage. So up at the top, you can see on the left side, those inside the person, on the right side, those outside the person. The top, you'll see a number of factors related to increased energy intake. The bottom, decreased energy expenditure. And in the middle, it's those that maybe affect both, or the effect on energy and intake vis-a-vis expenditure is unknown. Don't expect you to try to read all of these or to process this information. It's only to show that it is a very cluttered field of potential contributants to body weight. It is not as simple as patients need to move themselves back from the table or to take an extra walk. So what I want to do is try to simplify the previous couple of slides a little bit and come to an understanding of obesity. So yes, at the top of the slide, again, we can see that body weight is a function of calories in versus calories out, but we can't stop there. That balance is determined heavily by what happens in the brain. And what's highlighted there is the hypothalamus. That's not the only brain organ that has an influence on feeding, but it's certainly very important in the homeostatic realm of eating. But the brain is receiving signals from the food that we consume, the environment around us, and certainly socioeconomic status factors put us in different environments and situations that influence food intake and exercise habits. But I think importantly, if we go deeper within the body, we can see that the appetite centers of the brain are receiving signals from the stomach, small intestine, the pancreas, and even the fat tissue itself. Once thought to be just a storage depot for extra calories, is actually an endocrine organ, which is contributing, or excuse me, it's associated with satiety. I won't get into genetics or medications, only beyond saying that over 100 genes associated with body weight have been identified, And of course, there are several medications used to treat very common and serious diseases that may have the desired effect of improving those diseases, but the undesired effect of increasing body weight and promoting obesity. So obesity is complex. I want you to have that understanding. And it was now, 8 years ago that the American Medical Association proclaimed to agree that obesity is in fact a disease. The American Medical Association is joined by a number of other professional organizations as well as government associations. This is not an exhaustive list by any stretch, but the idea that obesity should be thought of as a disease, not just simply a failing of willpower, is coming more into mainstream. And I think that's a good thing. As of 2018, when these data were published, about 4 out of 5 healthcare providers did agree with the statement that obesity is a disease, but only about 2/3 of people who themselves have obesity and about 2/3 of employers or representatives of employers in this survey agreed to the statement that obesity is in fact a chronic disease. And despite the fact that many providers think of obesity as a chronic disease, many patients do, only less than 3/4 of patients with obesity have had any conversations with their primary care doctor about weight in the past 5 years. And when they do bring up weight with I'm sorry, I said primary care provider. Sorry, this was any healthcare provider, so it's broader. Before they've had any conversation with a healthcare provider, they've taken it upon themselves to try to lose weight 7 times on average before bringing this medical condition to their doctor, because it's very much internalized to patients that obesity is their own problem and something that they need to kind of quite literally tighten their belt on and figure out on their own. So why do patients with obesity not come to their doctors aside from or why don't they come to them as they would with other conditions, aside from the internalized belief that they should manage their weight on their own? There's an experience of bias that many patients with obesity report in the healthcare setting. As an example, there's lots of research to show that healthcare providers treat patients with obesity differently than they do patients without obesity. And in this particular study, those who had a body mass index in the class 3 or severe obesity range were assumed to be non-adherent to medication regimens generally. So this is one area. Healthcare is one area in which people with obesity experience bias. Of course, there are many others. My mentor's mentor several decades ago, Mickey Stunkard, said that anti-obesity bias was the last socially acceptable form of prejudice. I don't know if that is the case, but it certainly is a continuing form of prejudice. And about 5 to 10% of individuals with obesity report frequent experience of weight bias. Before you think, look, this isn't me, I don't have negative attitudes about people with obesity. I think everybody is equal. Their body weight doesn't influence how I think about them as a person, et cetera, et cetera. What you're talking about is your explicit bias. So the explicit bias is what we acknowledge, what we are aware of in terms of our thoughts. So if I say fat people are lazy, that is an example of explicit bias on my part. Now, if I say there's no difference between people with and without obesity in terms of their work ethic, et cetera, but I make assumptions about my colleagues with obesity and their ability to work long hours, to work hard, that is implicit bias doing its job. So implicit bias is that which we hold unconsciously that may affect our behavior. And it may be implicit bias which underlies some of the difficulties that people with obesity have in accessing care. So for instance, roughly half of people believe that the primary purpose that people seek bariatric surgery is cosmetic, where of course we know this is a very serious and life-saving procedure, for many people. And if we turn then to medical coverage and compare how obesity is managed versus other diseases, we'll see that all states cover a range of diabetes medications, up to 60 of them covered in each state. And when we turn our focus then to anti-obesity medications, only 9 states have any coverage of anti-obesity medication for their employees. I believe this has now been increased to 10, but we're still quite a ways behind. So by limiting access to medical care, by kind of poo-pooing bariatric surgery, clinicians' hands are tied. This is the ACE algorithm for the treatment of obesity, and ACE I'm actually using to represent 2 groups. That's the American Association of Clinical Endocrinologists and the American College of Endocrinology. They put forward this algorithm, which, like the previous eye charts that I've showed you, I don't expect you to try to read and process this, but it's here to demonstrate that obesity, like diabetes, can be treated algorithmically in terms of assessing the severity of the problem and selecting intensity of treatment based on the severity of that problem. So in patients, regardless of their body mass index, if patients have a number of weight-related comorbidities, they can proceed to more intensive treatment options. Unfortunately, what's typically offered in clinic and in employee wellness programs are things that would fall under the category of primary prevention interventions: healthy meal planning, recommendation to increase physical activity, some health education, increasing access to exercise equipment. Those are great for patients who have normal body weight or who maybe have mild obesity and no weight-related comorbidities yet. But when a patient is already at a body mass index of 35, they've already developed type 2 diabetes or sleep apnea, that is vast underuse of resources to use those interventions. And it's certainly not consistent with evidence-based practice to rely on those very minimal interventions for patients who require more detailed and intensive care. Obesity, as we said, affects, it's an accumulation of body fat affecting health. And this is a very non-exhaustive view of the many ways in which obesity can affect health, both metabolic and mechanical, as well as mental health. Not shown on this slide, but of course, having made a lot of news over the past year and a half, is the effect of obesity on COVID-19, not on the transmission, but on the severity of disease associated with COVID-19 and death from the disease. Of course, this obesity was one of the more common comorbidities associated with hospitalization and death, behind only hypertension. So the health effects of obesity have really come into sharp relief over the past year or so, when previously oftentimes it's shrugged off as a cosmetic concern or something that patients really should just kind of bite their lips and take care of on their own. The good news about obesity and its effect on health is that you don't need to eradicate obesity in order to see an improvement in obesity-related conditions. With weight losses as small as 5 to 10% of initial body weight, a number of studies have demonstrated reductions in the prevalence of type 2 diabetes among patients who are at risk, or a reduction in cardiovascular risk factors, improvement in sleep apnea, et cetera. And I think potentially of great interest to this group is to reduce absenteeism and presenteeism. So I'll close with this thought before handing it over to Abby, that any one approach to obesity, or any one part of a system that is attempting to address obesity, whether it's healthcare providers and the clinical systems, whether it's patients, family members, et cetera, on the more individual level or community level, none of these is likely to succeed on their own. And so what we're hoping to establish is an integrated model that includes all stakeholders and joining hands and efforts to make all options available to patients with obesity so that they can manage their chronic disease. So with that, I will stop. And if I can do this smoothly, I will stop sharing my screen. I think we're back to, Jeff, you're muted.
Thank you. So thank you very much. Very, very helpful foundation for our next speaker, Abby Aberman. Abby leads the Health Strategy and Communications team and is the manager of benefits programs for Heb Grocery out of San Antonio, Texas. So Abby, take it away.
Awesome. Thank you so much, Jeff. Good afternoon, everybody, or good morning, wherever you are. It's so neat that we can do this virtually. I was telling the group earlier, though, that I am actually in the office today and that I've had 2 in-person meetings this week, which is just seems like a really big deal after going through a year and a half of working from home. So hope everybody is doing well. And I'm just thankful for the opportunity to share the HEB story with you today. Because I know we are all so spread out, I thought I would start by sharing a little bit about HEB, who we are. We are a grocery retailer, first and foremost. We employ over 120,000 employees that we actually call partners. So if you hear me say partners in my presentation, I'm referring to our employees. We see about 10 million customers per week in our over 432 stores. Our company has been family owned for over 115 years and actually partner owned. We actually all have a stake in the company, which is really great. We operate stores in Texas and also in Mexico. We actually have 70 stores. It's not included in that 432 count in Mexico. We have a number of different formats at HEB. So we have just our regular general grocery store. You can go in and buy everything under the sun that you can imagine. We have a format called Mi Tienda that's more serves, I guess, what you would call maybe a Hispanic culture. There's lots of different products that you can find there that are what those customers seek. We have an HEB Plus format, which is just a really, really large store. And in some of those HEB Plus stores, you can find like our Mia's Mirror boutique, which is a fun little place you can buy gifts and clothes and different things. We also have a Jovi Smart Shop, which is where you can go and buy bulk items. We have Central Market, which is kind of our more high-end foodie, we call it foodie markets. They're similar to a Whole Foods. And we also have a company called Favor, which is our delivery arm. We joined with Favor a couple of years ago, and they go and deliver groceries and other things to our customers for us. They were instrumental during COVID, as you can imagine. We also do our own manufacturing. So we make things like chips, ice cream. We have a dairy plant. We have a bread plant. We have tortillas that we make. So we do a lot of manufacturing. And of course, we have to have a place to store all those goods. So we have 19 support centers for our warehousing team. And we also have our own drivers that drive all of our goods around Texas and Mexico. So when I want to share with you, of course, today more specifically about who we are from a health and wellness standpoint. So HEB has really been dabbling in the health and wellness space for a number of years. It's, I guess, really dove in 2008 when we started doing biometric screenings for our partners. At that point, we were just kind of doing what most everyone else was doing, and we were tracking points. We were a participatory-based program, asking our partners to complete challenges and track their steps and do those kinds of things. And of course, we were rewarding them with a premium reduction on an annual basis. They did certain things. In 2015, we transitioned to what we like to call our clinical engagement phase, where we said, okay, partners, if you have biometric screening results that are out of range, we want for you to participate in a class or a program that was vetted by our benefits team to help you improve your health. And so long as you participated and you completed that program, you would still earn the full premium reward. This time frame within our sort of health and wellness journey was a really great opportunity for us to gather data and better understand the impact and the effectiveness of some of the programs that we were offering. So based on what we learned during that time, we were able to either transition something, we were able to take something completely off the plate as we moved into our current phase, which is more of a very strict outcomes-based health and wellness program, where we're looking at biometric results and asking our partners to meet certain biometric ranges in order to earn their premium reward. We have an improvement model, which means if you screen this year and you don't meet your results, we're going to look at, we're going to have you screen again next year. And if you improve by a certain amount, we're going to reward you with the same premium reward that you would have gotten if you were in range for every single one of your results. We knew that when we offered this type of program that we needed to provide all of the right, widgets and programs and services to fully support our partners who were looking to make or meet their improvement goals. So we kind of tried to string together some benefit plan design offerings that would really truly support our members in their health improvement journey. We engage spouses, so they are asked to screen as well if they're on our medical plan. We do have a tobacco surcharge, and we felt like this transition to an outcomes-based program was really, really connected back to our business purpose, which is because people matter. We encourage our partners to take ownership of their health and find the program or the service that best suits their needs in order to make the improvement that we ask them to make. And I'll share a little bit more about some of those programs with you here in a minute. Just for those of you who like to know more about how we reward our premium reward, this is how it breaks down. We ask our partners to get screened. If they have an enrolled spouse on the plan, we also ask them to get screened. And partners who are in the green range, which means they've met our standard, they earn dollars that accumulate towards their ultimate premium reward. If they do not have a green, so they're in the yellow, moderate risk, or red, high risk range, then we look for them to improve each of those results by 3%. We do look at body mass index, cholesterol, total cholesterol, blood pressure, and I'm blanking, glucose, blood glucose. So those are the areas that we look to. So when we look at obesity prevalence within our population, in 2018, that was when we first started our outcomes-based wellness program. The average BMI of our population that screened was 29.9. And when you look at the actual breakdown prevalence of the prevalence of obesity amongst those partners who screened was 44% of the total. I was able to pull some more specific RX, so prescription plan data and also medical plan data for obesity starting in 2019 when we began covering obesity medications. So you can see in 2019, while our average BMI went up amongst our total population, our prevalence of obesity based on BMI did go down slightly. And we saw that about 7% of our membership actually started utilizing a prescription medication for obesity. But we only show about 2% of our total membership that has an obesity diagnosis documented with our carrier, Blue Cross Blue Shield of Texas. That's kind of carried over into 2020, and it looks like the trend is still very similar looking at the 2021 data. In 2020, like most of you, we had a much smaller biometric screening sample because we had to cut off our screenings or end them very early. We also had a lot fewer claims, but we still did see that some of our our partners were taking their obesity medications, and we're seeing the doctor because we did have some claims with obesity measures documented 2% again. In Texas specifically, what I've been told, doctors are not diagnosing obesity, especially as a first disease state, even secondary, mainly because of how they're paid. I think probably all of you experience this as well, but we always have a very, very low prevalence of obesity when looking just at medical claims, which is why we rely so heavily on our biometric screening data. So I mentioned some of the supportive plan design offerings that we implemented when we moved to our outcomes-based program. One of the big things that we did, and I'm going to talk more specifically about here, is that we decided to start covering weight loss medications. We were able to create and implement a process that's managed by our HEB pharmacy teams, where we can track our members who are utilizing those medications, their progress with the medication. So are they losing weight? Are they, how many times they're refilling, how long they're staying on the medications? That's been a really great program for us because it gives the member the opportunity to talk to a clinical pharmacist to better understand, the impact of the medication. We also employ at HEB registered dietitians. These dietitians work in our stores. So in each of our regions, they go out, they actually visit with doctors' offices and invite them to refer patients to them. They can do grocery store tours. They're really helpful on the health education front for us. And during the time where we were doing clinical engagement, this was one of the interventions that we studied. We looked at the partners who engaged with a registered dietitian and their success in improving their biometrics, and also reducing their healthcare costs over time. And we did see that we had a positive ROI and a positive health improvement offering for the folks that engage with the registered dietitian. We've also really been dabbling in and now feel like we're really engaged in this digital therapeutics concept. So right now, we just launched a new program in April, and we're already seeing participants in that program average weight loss of 8.8 pounds. So doing very well in that program, and we find it to be very helpful. We also worked with our EAP vendor to procure, if you will, a network of counselors that are skilled in motivational interviewing, readiness to change, so that they could help our partners who maybe didn't know how to get started and weren't interested in just jumping right into a nutrition plan with a registered dietitian. These counselors are helpful in getting our members where they need to be in order to start making changes and identify any barriers or roadblocks to making the change needed. Again, we do our screenings. We offer free screenings for our partners throughout the year, so they can go and get it, of course, during our partner health screening campaign, but also in our pharmacies, they can go back and visit and just do check-ins on how they're doing and consult with the pharmacy team at any time. Then we also have, we call our Magenta Health clinics. These are near-site primary care medical home clinics that we own and operate. The Magenta Health team is very helpful in referring all of our partners to utilize these programs listed on this slide. They're also were very helpful and instrumental during COVID as far as telehealth was concerned, and with testing and also vaccines. So the Magenta Health Clinic has been a really, really great partner of ours in just kind of referring and really owning all of these pieces for us. They also do some health screens, of course. So more specifically on the anti-obesity medications, this was actually one of those, benefits manager challenges that we had to work through. We were worried that if we started covering anti-obesity medications, that everybody would come running. They'd all want to take anti-obesity medications, and they would start and stop and may fail, whatever the process might be. Or that people would have side effects, and it would just be dangerous to cover, because we still had, some old school thoughts about what anti-obesity medications could do for an individual's overall health and wellness. So we knew, based on our biometric data and just the prevalence of obesity in our population, that we had a need we had that this might be something that would really help an individual meet their goals, really be excited to participate in our health and wellness program. So we knew that we had the need. We then had to go and educate the team. So our leadership team, the HR teams, to help them to better understand what offering an anti-obesity medication coverage meant for them and how it could really help partners, and really just how great these medications are for an individual and how far they've come from the 90s when, you know, it was less successful. We also worked with our PBM to build a financial model. We had to take into consideration, of course, our copay structure, and we were utilizing kind of a guesstimate on how many truly would come and utilize these medications. And then we had to consider, of course, PA expenses and other things that the PBM would charge for administering the benefit. And then, of course, how to treat generics, because the generic medications on the market today are actually not that expensive. And we found when we were doing our study here was that we already had members paying for out of pocket for these anti-obesity medications. So we knew that this was definitely something that people were looking into, doctors were prescribing, and that we wanted to help our partners be successful with. So a little bit more about our we call it a weight management program. We wanted it to feel like it was something that they could step into that wasn't, you know, labeled. It was kind of innocuous. It made them feel, you know, okay about saying, I'm going to participate in the weight management program as opposed to anti-obesity or anything labeled with obesity. So what we did was we went to work with our pharmacy team. We are so very lucky to have a team of pharmacists that sit in a call center. It's called our Reach Center. And every AOM that is prescribed to an HEB member, there's a message at point of sale to the pharmacist that say, that the partner can receive a reduced copay if they speak to one of our pharmacy teams. So it's almost like we've sort of implemented our own prior authorization process. So the script stops, the member then goes back and chats with the pharmacist at our Reach Center. And if they do that, they provide a starting weight and a starting BMI, validate the diagnosis with the physician, and then they can get their medication. And then every time they go for a refill, they're going to go through that same process just so that they are, again, being tracked and making sure that they are in compliance with the manufacturer's recommendations for utilizing the medication. So what we found over the past couple of years of utilizing this is that 83% of the scripts filled are actually generic. When we went into it, we estimated pretty high on how many would jump into an anti-obesity medication treatment. And we've only spent about 25% of what we planned for. We have an average number of fills, 5, and 28% of our utilizers have actually been utilizing an AOM since 2009 when we started covering them. So we're seeing some pretty good adherence. We're seeing some folks who are likely getting a lot of benefit out of it. So we are very pleased with that and excited to really study how they're doing and take a look at their biometrics this year. So after implementing our outcomes-based program and really fine-tuning the benefit plan design that we were offering to our partners and their families, we were able to realize for the first time in our over 10 years of collecting biometric data, significant improvement during our 2019 health screenings. So I'm going to share a little bit about our results now, and just wanted to kind of set the stage for everybody so that you understood our cohort. Of course, cohort are those individuals who've been screening with us every year since 2008. We actually have a pretty high tenure at HEB, so it's not surprised that we have been able to maintain this same cohort without starting at different years of a very significant population size. So it's really exciting. I get really excited when I see this data every year because it's so great to be able to track somebody's progress. And we know they've aged. We know they've all gotten older. but we can see how their health is doing. We have a fasting glucose cohort as well, because in 2011, we started asking partners to fast for their glucose. So everybody in that has been fasting on their screening ever since 2011. So the glucose numbers that you see are from this fasting glucose cohort. So I apologize for the busyness of this slide, but if you're just paying attention to like the red range, this means those are the folks who are out of range according to our healthy standards. And you'll see that we were able to recognize significant improvement in all of our biometric categories from the year prior. So we were really, really excited about these numbers. Like I said, it was the first time that we saw anything significant as far as improvement was concerned. And we did see a 4% reduction in our prevalence of overweight BMI over the course of the 1 year. This is our total population. So when we look at everybody who screened, we still did well as far as the improvement was concerned. And then when we look at our cohort specifically, the same thing. We saw significant improvement in every category over the course of the 1 year from 2018 to 2019. We did see with BMI specifically, it was a little bit of an increase in prevalence since 2010. But again, aging, all of the categories and factors to take into place. But that category and also glucose, those were the two areas that we didn't recognize change or improvement from 2010. But the year-over-year stats all improved. And again, we were really, really excited about that. And I think most of us we're in population health in any form can appreciate significant improvement over the course of a year. In addition, what we saw in our screening, so even though perhaps not all of the categories improved or not everybody improved in everything, we saw a lot of reduction in the risk count. So on the right-hand side of this slide, we reduced the 5 risks was down 28%, 4 risks was down 14%. So again, we know that just reducing one risk factor is really impactful to overall health and wellness. So we are really pleased with that. We also offered a little bonus for everybody who met their goals. So if they weren't green, but they did meet their 3% improvement goals, then we gave them like a cash bonus after the biometric screening campaign. It was separate from the premium reward. And we had 33% of our screened population who met all of their improvement goals, and they were able to get that extra cash bonus. So that was, again, another really, really great result that we were very proud of. So what's next? I think we're trying to get everything back on track after a crazy COVID year, but we are in the midst of our partner health screening campaign right now. So as I mentioned, I'm really excited to see the cohort screening analysis that we're going to be able to do at the end of our campaign. And, I think my expectation is that we likely won't see continued improvement since our improvement in 2019, and that we may see a little bit of a jump as far as prevalence is concerned, just because of the year that we've all had. We're also looking to study our anti-obesity medication, so that PA program that I mentioned to you earlier. We're going to look at that, and we're going to look at the cohort that has been engaged in that program and determine their health improvement over the course of time. We're also looking at some new plan design considerations. We do cover bariatric surgery. We have for a little while, but we're looking to enhance that with some additional support metrics for folks who do decide to go that route. The support metrics would be things like engaging them with our registered dietitian team. It would be, maybe some shopping tours. It would be connection with our EAP counselors, those kinds of things. And then I think what one of the biggest takeaways as I was thinking about some of the hurdles and things that we've been through is that we really need to target better. So I think that while we have all these wonderful benefits available to all of our partners and members, It is truly hard to get people to engage in those programs, to go see the registered dietitians, to understand that anti-obesity medications are covered as part of the plan. So we're looking forward to doing some targeted communications campaigns, meaning that we may, just gently nudge folks who we know have certain risk categories to engage in specific programs. So that's what we have on tap for the next few months, and we're hopefully can come back and share some additional exciting data and some exciting news from some of our new changes that we implement for 2022.
Wonderful. Thank you very much, Abby. That was a great presentation. I can just tell from the number of questions that we have coming in that it's got a lot of people thinking, especially with the foundation that Dr. Fabricator laid for this. One question I have, and especially given that this is fundamentally focused on what's happening in the workplace. So of course, economic issues are always a concern. And actually, I've learned a lot about obesity from many of the people who are probably watching, but one I remember in particular from Ted Kyle is he made a comment once to me about not looking just at the costs from reduced obesity, et cetera, but looking at all the other things that happen, like the lower costs for pharmaceutical expense for the company because diabetes is well controlled, or what about the economic benefits of less absenteeism, that type of thing. A more holistic approach certainly fits with the nature of obesity. Mm-hmm. So when looking at the costs at HEB, somebody, I guess, at some point is going beyond just, hey, this is good for employees for their health, and also putting a pencil to paper. So what were some of the things that went into that analysis?
So we don't really have a good way to measure absenteeism or presenteeism. Mm-hmm. Unfortunately, I think a lot of employers are in that boat, but so we don't have anything like that. I mentioned our study that we did with our registered dietitians and the partners who engaged with them. Mm-hmm. We've done a similar study on cost reduction with we have a team of nurses, social workers, those kinds of folks that work for Blue Cross Blue Shield of Texas, which is our insurance carrier. And we had the same results. So members who engaged with them and actually those were better cost savings over the course of 2 years, as opposed to just 1 year with the dietitians, that we had cost savings there. So we do look at that. It's about time for us to kind of redo all of those studies because it's been a couple of years. So we'll likely add that to our list of things to look at as well. But we definitely believe in that there is cost reduction when people improve their health. And from what we've learned from our physicians and others that we've consulted on that, I mentioned that 3% improvement range is that's significant enough, even though it might sound small. It's significant enough to really improve overall health and wellness and reduce costs. So that's sort of where we went with that.
Well, it sounds like it's more of a qualitative judgment than a quantitative one. Just the belief that, hey, if the partners are healthier, on balance, that should lead to all kinds of improvements, even if we can't put a number on it, let's say.
Yeah, it's, and I think I saw somebody just ask, but we have an analyst that works on our benefit plan, and we use risk scores, and we use things like that to determine where people are, so to kind of create an even playing field. And then we look at cost over time of course, people utilizing the benefit plan, and we see a change in the amount of claims dollars that they are utilizing over the course of from year to year. And that's really how we look at it. So we've done all of that, which is why we believe so strongly that these programs do work.
Mm-hmm. Cool. Well, hey, we have quite a few questions from people attending, and many are clustered around this topic for you, Abby, to hearing about the digital therapeutics that HEB is using. You touched on that in your presentation.
Yes. So right now we actually are working with a company called Onduo, and they digital therapeutics is like where you can connect a device that tracks health data. So In this case, it's a blood glucose meter. And Onto actually uses continuous glucose monitors. They have access to an endocrinologist that provides telehealth and then prescribes the CGM. And this is for type 2 diabetics. So it's a different way to treat type 2 diabetes. And we've been in this now for a little while, and our members, our partners really love it. They find it engaging and easy to do, easy to understand, and the data that we get is really helpful and beneficial.
Mm-hmm. Yeah. Actually, that's kind of a follow-up question from Patty Neese is, what do you do with the detailed information you collect about your members' use of obesity medications, if anything?
So we're going to study it. That is the intent behind collecting that. Of course, since we have pharmacies, we have clinics, we have our benefit plan, we have a number of shared entities. I don't necessarily have readily available access to that information, but our analyst that we work with does, and she correlates it all. We have a giant spreadsheet that we get to see every year and pull data out of, and so we want to know. My biggest curiosity about the anti-obesity medications is, how long are people staying on these medications, and is it something that is maintainable? Should they no longer take the medication? So I think it'll be interesting to see people who fall off potentially, what happened to their, or what changed about their body weight or their BMI over the course of 2 years after they stopped taking the medication. Mm-hmm. So just general curiosities like that we'll be able to look at.
Yes. Interesting.
Mm-hmm.
If I may chime in there and maybe get ahead of the data a little bit, I would expect, as I think many people on this call would, that when medication use stops, that the weight will come back on, just as would be the case if patients were treated with insulin and stopped use of that medication. And I think it's very common for patients to not want to be on a medication into perpetuity, and to sort of achieve their goal and be done. But I think it is important from a clinical standpoint to begin to build the expectation that this is a chronic disease and needs to be managed chronically. And and the data from different therapeutics, whether they're drug or diet and exercise, actually show that discontinuation of the therapy leads to a loss of effect. And that's what you would expect with a chronic disease. Mm-hmm. So I hope your members do continue on. If they're having success, I hope they continue.
Dr. Fabricatore, is there just like a general comment about pharmacotherapy? Is that the case for all compounds, or are some viewed as, makes me think of the mental health world, where maybe somebody's taking an antidepressant to actually get them through a period until they have the benefit of therapy and life alteration and things like this, so they can manage their illness without the benefit of pharmacotherapy?
Yeah, so depression generally is episodic, whereas obesity is chronic.
Okay.
So it's a different disease in that regard. Of course, there are some similarities. Of course, it's episodic but recurring in the case of depression. Mm-hmm. Obesity is chronic, and the biology never stops. Frankly, the survival instinct. Once you've depleted your fat stores, your body works really hard to put them back on. Mm-hmm. And without intervention to counter that very natural process. Of course, there are exceptions. Some people are able to maintain a weight loss after discontinuing a drug or a weight loss mm-hmm. effort. But the very common result and the expected result is that there will be some regain.
Interesting. Well, we touched on mental health there briefly, and maybe we can switch actually to a question that came from Joe Naglowski at Obesity Action Coalition. And he was curious to know, directed mainly for Abby, but I think it's relevant for both of you, what was the employee receptiveness towards this focus on obesity at HEB, bringing comprehensive obesity care or something close to that, did employees feel more empowered on balance or a little bit targeted? What feedback did you get?
Yeah, so very, very interesting culture at HEB. It is definitely paternalistic, if any culture is. It is one where I think that we've built enough trust with our partners that when we ask them to do something, they generally do it. It's very interesting. However, when we did kind of transition to this new incentive program, we were asking for improvement, asking them to meet certain metrics. We did see a good bit of drop off in our participation in biometrics. Understandably so. We tried to study that. We did some surveying and tried to lean in a little bit and figure out, well, what was it about it that made you not participate? And honestly, the feedback that we got was, oh, I didn't know about it, or, oh, I just missed the deadline. So it was just very strange. It didn't match up with what we thought at all. So we didn't get a lot of pushback. A lot of people, what we hear from our partners every year is that the BMI is ridiculous. Why are you measuring BMI? Those are the kinds of pieces of feedback that we get, or, oh, the blood pressure range is too hard, things like that. So we have to do a lot of educating on BMI and why we have to use that as a population health metric. But of course, we also have appeals and waivers and a reasonable alternative for our program. So partners who just don't want to play can absolutely use that form and still earn their full premium reward. But honestly, we haven't heard a lot of anything negative, I would say, in relation to focus on health improvement.
Mm-hmm. I love this question from Joe, and there are two aspects of your program that kind of give me some confidence in the absence of hearing. One is you described more of a carrot program than a stick program, where there are incentives for achieving goals rather than punishment for not. And then the other, and I think this is critical to the success of the first part, is the partial success. So you've got goals, and then you've got partial credit for a 3% change in the right direction. And that makes the goal reasonable and achievable, or makes progress achievable and that incentive achievable for many more people. So if you're beginning from a BMI of 42, and I don't know what the goals were, but if it's to get below 30, it's not going to happen for most people. But a 3% change, not only is that achievable, it should be, it will be for many patients, clinically meaningful, and it may be economically meaningful. And I guess your data will show that one way or the other.
Yeah, definitely. And I think I saw this question come up, but it is, for BMI, we look at a 3% change in your overall body weight. So it's not specific to BMI. That might be a little challenging too, but yeah, so it is small and very incremental and achievable. And I do think that there's something there. And one thing that I would love to figure out how to do is study the behavioral economics behind all of it, because we felt like our partners responded to, here's a goal. We want you to go figure out how you personally want to meet that goal. Go and do it. We'll talk to you in a year. And that worked for some reason. I think that's very interesting. So I'd like to know more about that. So if anybody has any ideas, can look at that. I'm open to hearing them.
Oh, that's actually super. That's one of the main goals of us having this seminar today, is to bring those more practical ideas and get the creative juices flowing for those that are observing, to think about how they can make change and implement things in their own organizations. So
yes,
certainly appreciate that. And I'm sure there'll be a lot of collaboration. I wouldn't be surprised if you'd hear from several people afterward with direct questions. Hey, what can we do in our organization to mirror what you had and not reinvent the wheel?
Yeah.
Dr. Fabricator had a slide, and it's funny, you're right, there can be no overview without the CDC slides, but talking about the different ways that obesity affect different portions or segments of the population. And I'm wondering now, among the employees at HEB, what are you watching that? Is that something that you're affecting a little bit, especially because you have grocery stores or stores that focus at least on the Latino community versus, I guess, the more general population, if you will? Are you seeing different reactions among the partners that work at one store or another?
I wouldn't say different. I think we take all of that into consideration. I mean, we are in Texas, and it's really interesting how Texas in certain parts of the state have different traditions. Like there's this beef and barbacoa, Big Red and barbacoa. That's a thing here in Texas, like Big Red, the soft drink. And we sell that as a combo sale in our stores in certain regions and districts, and where it's popular, of course. And so that of course is a very cultural thing that we have to deal with and manage. I think again, we're so blessed to have our registered dietitian team who can take that concept and say, okay, you like beef and barbacoa or Big Red and barbacoa. Let me give you an alternative that's very similar. So health education has become a very big deal for us. And like, for example, the registered dietitians, they'll record webinars for us. They'll do cooking demonstrations that we can post on our Healthy at HEB website. We have what we call a health coach dashboard, where we created a game where you can go in and you can select certain foods to build a healthy plate. So trying to do some interactive things that give people the opportunity just to learn. And so I think that's been a big help to us. And we do find that our partners are engaging in those types of things. So it is interesting, but culture and just trying to help people understand general basic nutrition is a big challenge. For sure.
Interesting. Well, you mentioned the registered dietitians, and that actually has been the topic of several questions. Just one to kind of dig into it a bit is, one question was, did I understand you to say that the registered dietitian benefit showed a health claim improved cost over the course of 2 years compared to just over 1 year? And first of all, if that understanding is right, does that mean that longer treatment by a registered dietitian for an individual actually improves cost savings? You know, might just comment on that specifically, or just in general on the role of registered dietitians in the program.
Yeah, so it was actually what the study actually showed. We looked at a 2-year span of time. Partners who engaged with a registered dietitian at least 3 times. So we cover 3 registered dietitian consultations for free as part of our benefit plan annually. And then after that, it's a $30 copay. And so we looked at everybody who participated with 3 visits. And then over the course of 1 year, there was recognized cost savings and health improvement. So what I mentioned, the 2 years was our partner care team, which is the group of nurses with Blue Cross Blue Shield. The partners who engaged with them, they had greater cost savings in year 2 than in year 1. Post engagement with that team. So I don't know if I could necessarily say that longer engagement with the registered dietitians is more beneficial, but that was just what our study showed. So in my mind, that means the partner care team participants had over time cost less because they weren't seeking care as much potentially, or they weren't needing to fill those insulins or whatever they were utilizing. And we do find that participation with the registered dietitian does fall off after 3 visits. But obviously that's how our benefits designed, so that's probably why. But it's generally what we see.
You know, a question for both of you is the importance of support. Because I appreciate Dr. Fabricator's comment that it's a chronic disease. But many times there's that initial stage where someone gets engaged, they're taking advantage of the benefits their employer is offering. And so they have some early success, maybe 3% reduction in their body mass index, or even more importantly, a reduction in their body fat percentage, since excess adipose is a major focus. So they reach that point. What resources are in place at HEB? What things need to be in place, Dr. Fabricator, to help maintain that afterward, to not have a relapse? Is there anything in place at HEB for that, or is the focus just on, hey, let's have that initial reduction?
So I kind of look at a lot of the resources that we have in place as preventive. So if we can get people to a certain state of health, then they would still be able to utilize the resources that we have available to maintain or stay on track. Okay. And I think a lot of times too, with like my perspective on registered dietitians would be that they're providing, a nutrition plan and helping people to establish good behaviors that are maintainable over time. So, and that's really important to us too. We don't want to just put something out there that's going to be a quick win or a shot in the arm of mojo to reduce your weight. That's not our intention at all. We want something that will help people maintain and over time. Mm-hmm. Yeah.
Looking at the behavioral weight loss literature, one thing that is found to be important to help minimize regain, and I want to be clear that it's not a prevention of regain, but to minimize regain is continued contact over time. So I don't believe that there are any special interventions that have been demonstrated to actually halt weight regain, but you can slow it down. A good example is the Look Ahead program, or maybe more people are familiar with the diabetes prevention program. It's sort of the basis for all of the standard lifestyle modification programs that are implemented in the community. And despite continued treatment in those studies, there was a regain. And again, this is the process doing its thing. This is the body going through its natural process of trying to replenish lost fat stores. What DBP found, for instance, is that even despite a modest weight loss to begin with, and even despite a regain of about half of that loss, there was still a significant reduction in the incidence in the study, it was type 2 diabetes was the main outcome. Mm-hmm. So there was a significant reduction in conversion from pre-diabetes to diabetes, despite the fact that weight loss was minimal by most people's expectation standards to begin with, and that most of it was regained over the course of the next couple of years.
Okay. Kind of a related question about helping to support the continued weight loss, and this is, of course, a practical thing for Abby, a practical question, but maybe for Dr. Fabricator as well. Can you have the benefit like this in place for employees and not have something also on the mental health side at the same time, given the important role the mental health plays with obesity?
I don't think so. I don't, but I also think that, like, for example, just the HEB, just being completely transparent, I think we have room to improve on mental health. I think it's changed so much over the course of the past year as well that we're constantly trying to solve for it. I mean, we have a mental health task force and those kinds of things. So separate from obesity and any other kind of health and wellness initiative, that's all happening. But I think because we knew that a lot of people might not be motivated to start, that we had to figure out how we could make our EAP benefit be of value to partners who were looking to improve their health. Mm-hmm. And so that's why we added it in. And it was helpful. It has been helpful. It continues to be helpful.
Jeff, my thought on that is, and I'll disclose my bias, I'm a psychologist. Yeah. So of course, I think that, mental health should be part of standard coverage. It is health. So I guess I'll leave it at that and won't climb too far up on the soapbox. But to answer your question, no, it shouldn't be excluded, or you can't do one without the other. Yeah. Not because of obesity, and obesity has a mental health component. So does every other disease, certainly chronic disease. Has a mental health component to it. So I would say that it should be offered alongside of all benefits packages.
Well, I knew that, of course, so it was kind of a softball.
Thank you.
a little plug.
Yeah, but no, just to understand that side. In other words, does it feel slightly incomplete then, at least as far as this? I mean, it's of course fabulous to see what's being done, Abby, at the HEB, and I appreciate the comment that, there is still room for improvement. And maybe that's a place that so often we focus on the physical aspect of it, but not the critical role that mental health plays in obesity in particular. Let's see, there's quite a few, actually one question, and well, it's actually come up several times, are the results that you have. You know, part of the reason, as I mentioned a couple of times already, for focusing on what HEB is doing is to stimulate thinking and ideas with other companies. Another aspect to that is to publish the results, to make those available in some way so that other organizations can use that as benchmarking. I don't know what plans you have in mind for that.
No plans really. You know, we're sort of we're a private organization, and if there's good opportunity, I think, then we would consider it. But we haven't really done any publishing. I've just done a lot of this, speaking to my peers and colleagues, and yeah, so that's kind of where we are. But you know, open to conversations for sure.
Well, I don't recall. Were you involved at HEB when this started?
Not in 2008. I've actually been with HEB for 5 years, but I was the one who made the change to an outcomes-based program. And it was like, we need you to come in and look at our program and make some changes. And we did. And I was like biting my nails the whole time, like, please let this work, let it be good. And, you know, it's been a really interesting journey. We've had a lot of fun, and it's so funny. I just got feedback from a partner who was at the pharmacy getting her health screening. She works with the benefits team, and the pharmacist said, "Oh, I'm so glad we're back to the improvement goals, and we're looking at that again after having a year off." She like complimented her on it. I was just thinking, wow, that's amazing. You know, people are you know, excited about it. So that's kind of a nice thing to hear.
Absolutely motivating to do more, I'm sure.
For sure. Yes. Yeah.
So if afterward, one of the companies attending calls you and they say, hey, we'd like to do something here. Now that you've been through it and you'd like to avoid them going through the same learning curve, what are the top 1 or 2 very practical things you would recommend? Like, hey, this worked, definitely do this. This didn't work, you can skip that.
Yeah. Let's see. I think the buy-in is really key. I know, like, a lot of times you hear people talk about leadership buy-in for health and wellness programs, but I'm talking more about like the people who will be out on the streets promoting this program to your employees, that having their buy-in and complete understanding of the program and the intentions behind the program is really helpful. You know, I went to all of our HR teams and spoke to every single regional field HR team and just told them about it, helped them to understand it, and then asked them to go help me get people screened. So that's a big deal for us every year, meeting with our wellness champions, the folks who can really help and encourage others to get involved and get engaged. So I believe that's really important. And also just being able to communicate it well, knowing your population well enough to know what kind of communication they're receptive to. For us, it's texting a link to a video, and the video is an expert giving advice and telling partners, giving them clear, actionable things to do that they need to do in order to achieve what their goals, or go get their screening, whatever the message is. Those are some of the things that we've done that I would say are helpful. Was there another part to that question? What wasn't helpful? Maybe.
Yeah, you know, to avoid, of course, somebody making the same mistake, because we'd like as many companies as possible to start implementing something that fits for their organization.
Yes. Yeah. Gosh, I'm going to have to think on that one a little bit. But obviously we've made mistakes. We've done things wrong. But I can't think of anything like big learning that I have in my head at this moment, but I'll think about it. Okay. And I can always circle back.
Okay, cool. Out of curiosity, I mean, do you know what got this whole thing started? You know, very often it takes somebody at the top who just makes up their mind that they want to see a change, but I don't know what happened with HEB.
Yeah. You know, I think it was that. I think in 2008, it was sort of a big deal. It was a big topic in a lot of organizations. And, you know, I think that we saw costs increasing. I think that we can visually see the change in health in some of our partners. And our CEO was very engaged and very adamant about it. We actually have a team that focuses on health and wellness just for our customers, of which the registered dietitians are a part of. So that is also a big deal. We feel very strongly that we influence the health of Texans, and that's a big deal for us. And we want to be able to not only provide healthy options and solutions for our partners, but also for our customers. So it absolutely is an organizational top level down initiative that lots of eyes look at and bless every year. So
as far as you know, though, there wasn't like a personal story that somebody had.
I mean, we have lots of those. We definitely have lots of those, but it wasn't not at the top, C-suite level. No, but it was just it's the right thing to do because people matter. As I mentioned, our companies first.
Absolutely. That's cool. Maybe for both of you, what could be done maybe with some of the people who are attending the webinar today to disseminate this information in a way that's most effective? I mean, are there other things where you feel like, oh, this would be a great way to get the message out, to share this with other organizations and companies?
Yeah, that's probably more for you.
You want to go in there? No.
While you gather your thoughts, I'll go ahead and ask the academic-minded folks who are in the meeting today to get in touch with you, because if you said that publishing is not necessarily something that you have considered or have done in the past, I saw one comment come in really imploring you to publish. I do think that this is that not just your results, but your methods are going to be really critical and can move the field forward. And if that's not your bailiwick, the publishing, there are plenty of people listening, I think, who can work with you on that data and disseminate it to at least the healthcare field and employer and benefit design journals.
Okay. Thank you. It would be really interesting. And it's funny because I don't know how many times people have emailed me like that RAND study. I don't know when it was published, but a lot of years ago that was, health and wellness programs that work do not work. And it's sort of like my mission to prove that wrong. But it definitely, it is an uphill battle. It's hard. I think getting people on board, it's hard engaging with your people in a very specific way to make change to their overall health and well-being. Just like doctors don't like to talk about it, it is hard to go and talk about it to employees as well. So I think that my advice would be to kind of line up your culture and, what the tolerance level of your employee population is. And then figure out ways that you can, as benignly as possible, slate things in and design programs that will be solutions that your employees can lean into because it matches your culture, or it matches your business purpose, or whatever that is. And then start just kind of shouting it from the rooftops and just keep peppering them with the same messaging over and over. I think that. But definitely before you do any of that, make sure you know what you want to measure, because that's important to be able to capture the data that you want to see at the end of it.
Oh, absolutely. So often the focus is BMI only, for example, and it's not really that great all the way around. Did you track, for example, the number of your partners that had pre-diabetes or diabetes that was well managed, or risks in that area as something kind of aligned with or close to obesity?
Yeah, so we do know that. So we track the blood glucose. So and we actually track A1C also. So like when you go to get a screening, if your blood glucose is out of range, then we test A1C, and then you have to meet an A1C metric. If that's in range, you get your premium reward dollars. So we have a lot of data in blood glucose as well. Plus, when we launched with Onduo for the type 2 diabetes program, we have Blue Cross Blue Shield sending them a file every month, and they go through and they pull out just the people who have a diagnosed diabetes claim in the system, or a diagnosis. And we use that as our targeted population for certain things. So we really try and target our population that way, so that we know that we're peppering them with the right programs that are going to most impact their health. So we do track that very, very, very closely as well. Diabetes.
Okay, yeah, good. Makes sense.
And we have a pharmacy program too for diabetics. So like if you are a diabetic and you're filling diabetic medications, or you need diabetic supplies, you get a reduced copay on everything for those as well.
Okay. Mm-hmm. An additional part of the carrot, as Dr. Fabricator mentioned.
Yes.
Well, we have just a couple minutes left. I don't know if, in light of the questions, or now if that stimulated any thinking on the part of either one of you, if you have any final comments, or as far as the presentation.
I'd like to just, I mean, Abby, you're getting a lot of very well-deserved kudos, and I just want to kind of add to that, and not just on the results, but again, as I mentioned about when I was talking about publishing, about the design, about the methods. What I think distinguishes your approach from many of those that I've heard, and I would love to see replicated more widely, is the integration of different elements of care. So it's the registered dietitians, it's the pharmacist meetings, it's the near site primary care clinic and medical home, it's the behavioral counseling. No one of those things by itself would likely have the results that you've had. And I think it's important, and again, it kind of comes back to the complexity of obesity, and just how hard the body fights to maintain it. It needs a comprehensive approach. And I think it's wonderful that the approach that you've put together pulls in all those disciplines and makes them available to your partners. Again, I think that's got to be responsible for the results that you're seeing.
Yeah, thank you. I think the same thing. Agreed.
Well, hey, thank you very much for an excellent discussion. As a reminder to everyone, today's webinar was recorded. The recording and the presentation slides will be posted to the BEOSIC website in the coming weeks. Thank you to everyone. Thank you to Dr. Fabricator, and also to Abby as well, for their great insight. And we hope you'll join us again at future BEOSIC events.
Thanks, everyone.
Thank you.